Good afternoon, everyone. We'll just give everyone a few minutes here or a minute or so to join us from the waiting room. So we'll just sit tight and we'll get started shortly. It looks like we still have several people entering, so we'll just let that trickle in and see if it slows down here, and then we'll start. All right, it looks like it's slowed down a little bit. We'll go ahead and get started. Good afternoon to most everyone, and maybe good morning to some. We're pleased to be here today. We are presenting on gradual dose reductions, lessons from the field. This is part one of a part two series. And we will kick it off here shortly. It looks like there's some more people coming in. All right, Mary, let's go ahead and get started. Next slide, please. Again, thank you everyone for joining us. Again, this is a part one of a part two series going over gradual dose reductions, lessons from the field. First of all, my name is Jessie Kenzie. I'm an account manager with Mountain Pacific Quality Health, as well as a registered nurse. I am delighted to be here today and co-present with David Lawless, PharmD, not only a pharmacist, but also has an MBA and is currently with Omnicare. David manages a group of 25 clinical pharmacists throughout Montana, Wyoming, Oklahoma, Utah, Arizona, and Colorado. And he works closely with the Board of Health and Board of Pharmacy in each of those states. He's an expert in behavioral management and has taught day-long workshops at state health conventions. And David brings over 25 years of experience in the long-term care pharmacy setting. And David's lucky enough to be joining us today from Ennis, Montana. So I'm pleased to have Dave co-presenting with me today. With that, I will say I'm going to just turn my camera off to save on bandwidth here as we get started. Great. Thank you, Mary. And next slide, please. So start our presentation today. We thought we would do a little bit of groundwork and start with some polling questions. So first polling question we have. Here we go. Do you know the percentage of residents in your center that are currently on an antipsychotic? We'll give you just a little bit to answer that, and then we'll see our polling results. Excellent. So it looks like about, oh, we still have some coming in. 69% answered yes, about 14% answered no, and 18%, I think I better check. All right.
I love it.
The next question. All right, thank you, Mary. And the next polling question. Oh, I'll let you share the results. Yep. All right, next question. Do you feel like you understand how antipsychotic medication use in your facility affects your quality measures or your 5-star rating? Perfect. Looks like that leveled out. So about 60% of folks answered yes, 15% no, and about a quarter of you maybe. Great, thank you. That's 73 responses. Awesome. Okay, next question, Mary. Are you aware of the percentage of residents, let's see, currently in the center that have dementia-related diagnosis taking an antipsychotic? You guys are over it, all over it. Thank you.
I feel like this is a test.
I know.
I'm nervous. I'm nervous.
These are good questions. These are good questions. Thank you everyone for your participation. This is great. So it looks like 61% said yes, 14 no, 25%. I think I better check on that too. Fair response, very fair response. All right, next question, Mary. Do you provide staff and family education on behavior management and non-pharmacological interventions? Nice. Nice. All right. Well, about 72% said yes, 7% no, and 22% it's a goal. Thank you, guys. Yeah. Okay, next. I think I have one more question. Is that right, Mary? There we go. Do you have a therapeutic meetings or committees, such as a pain committee or a behavior committee? And is your pharmacist involved?
Now, I'm really interested to hear the results on this one. Another really good question. All right, it looks like 62% said yes, they're on speed dial. About a quarter of you know we don't do that. 13%, I think I like this idea. Thank you guys so much for participating in those polls. This kind of helps lay a little bit of groundwork and helps set the stage a little bit. So thank you very much. With that said, I am absolutely delighted to pass on the microphone to Dave. Thank you very much, Jesse. As she said, my name is Dave Lawless. I'm a clinical manager with Omnicare, and this is kind of what I do, and it's what I really love to talk about. So any positive effect that we can have on the residents that we service makes me extremely happy. And really like to thank Mountain Pacific Quality Health for inviting me to participate. If you enjoyed today's presentation, I would encourage you to let them know that you'd like to hear more, because I love doing this kind of stuff, and love to kind of keep this going with, you know, quality education and working on some of the things together. So what I'm going to talk about, and I can't see, oh yeah, I guess I can see the slides. They're really small. Let me enlarge that so I know where we're at. So what we're going to talk about today is kind of mapped out here. We're really going to talk about why do we have to do this, right? We know we have to, the pharmacist tells us we have to, and the state reviews it. So I want to kind of give a little bit of backdrop as to why this all started. We're going to talk about focusing on individualized care plans and really focusing on, you know, taking care of the resident. There used to be, hopefully somebody's monitoring the chat box. There's a question in the chat box. It used to be, I think it was like pre-2013, where there was like a set of diagnoses that were restricted, and you could only use one of those diagnoses for antipsychotics. And you would get a citation if you didn't choose one of those diagnoses. That's gone away in the new regulation. So they're not looking at just a simple diagnosis to make sure that it's appropriate. They're looking at the entire care plan, and are you individualizing the care for each particular resident? And is that medication necessary? And are they free of side effects? So we're really going to dig into that some. We're going to talk about non-pharmacological interventions. I'm huge on trying to figure out how we can handle behaviors without adding a medication. And sometimes we can take a look at things that they're on and get rid of something instead of adding something. So we'll talk about non-pharmacological interventions. I'm going to turn it back over to Jessie, and she's going to talk about antipsychotic rates across the different regions. I understand we have several states on the phone. She's going to talk about minimum data set, the MDS, and kind of how that affects your star ratings, how it affects your quality measures. You really want to have somebody involved in that understands the right coding, and you want to make sure that they're very clear on the diagnoses, especially for antipsychotics, because if you enter schizophrenia, Huntington's, or Tourette's, it falls off the count for your quality measure. So that's a huge bonus. So if they have a diagnosis of schizophrenia and you put in dementia, then you're doing yourself a disservice. Jess will talk about that. And then we're going to talk about interdisciplinary teams and focused care. And that's going to go to that 38% of you that do not have a current behavior meeting and are not working with your pharmacist on meeting with specific residents. So next slide. Okay, so why are we talking about this? Back in before my time in the 60s, 70s, nursing homes were kind of well known as institutions plagued with abuse and neglect. They were places without dignity and respect, and they really wanted to do some investigation and try and figure out what they could do differently to take care of our residents. And back in the day, and I gave this talk to a lot of different people, and I've heard several people shaking their heads, and I've got to hear stories about it. But really, back in the day, residents would be tied down to a wheelchair with some sort of straps. They would be given liquid Haldol with a syringe, and if they acted up at all, they would just be given more Haldol and morphine, and they'd basically sit them in a corner. And we had the physical and chemical restraint issue. So in 1986, there was a blue ribbon panel selected by the Institute of Medicine that basically went out and did a comprehensive report titled Improving the Quality of Care in Nursing Homes. And for the first time, they made, Congress got involved, and they used the findings of that report to create what's called OBRA, and it was OBRA 87, which completely changed the quality of care in nursing home residents across America. And that's the start of the survey process. It's the start of when consultant pharmacists started coming into the scene, but we started to really look at antipsychotic medication use. And go ahead and go to the next slide. When they started doing some research in 2011, a research from the OIG, there was a report that said 83% of Medicare claims data from 2007 was for atypical antipsychotics in nursing homes, and 88% associated with conditions specified in the FDA box warning. So we'll talk about the box warning in a minute, but basically what that means is most of the antipsychotics that Medicare or the federal government was paying for were being used off-label, which means something that the FDA doesn't approve. And that was 83% of Medicare claims. So, huge cost to the federal government. And when you're using something off-label that's a dangerous medication, then that's really when they get involved. So lots of people got involved at that time. AMDA got involved, ASCAP got involved, OIG got involved. Go ahead and go to the next slide. It kind of flows into the next topic. But there was a Senator, Herb Kohl, that kind of used this as somewhat of a political platform. But The black box warning issue came about when the makers of Zyprexa actually tried to get indication for treating dementia. And their little process backfired. And in the process of it backfiring, the FDA asked for a bunch of more information from all the antipsychotic manufacturers. And they found, doing a meta-analysis, which means looking at all of the previous information, they kind of realized that there was an increased risk of death in the elderly, and specific to stroke or sudden death through a couple different means. But there was definitely an increased risk of death. And so they required what's called a black box warning, and the black box warning has to be, it really is a big black box warning on the PPI, which is the package insert, and it's something that's required to be with all medications. And if you have a black box warning, then it's something that we definitely have to monitor for. So immediately, different groups got involved, and the overall goal was, stop spending so much money on things that are potentially causing harm and they're so dangerous to use. Next slide, please. So pretty interesting. There's a lot of different, meds and dangerous meds out there. And what I was referring to is the package insert. And for those sad enough to know a pharmacist, that that's kind of our Bible. And the package insert is something that has to come with all medications. And it really maps out all of the different things that are in there. It's the indication, the dosing, side effects, the, potential warnings and things. And if you look at the length of the PIs, Coumadin is rat poison. Rat poison kills people. Simple as that. You use too much of it, you bleed and you die. That's a 21-page warning. And you look at Seroquel, it's 51 pages long. So it's less than 3 times, but it's over half. So you can imagine there are a tremendous amount of side effects with antipsychotics. And I'm not going to tell you that antipsychotics should not be used. There's definitely a time and a place for antipsychotics, but you need to make sure that you're doing a very thorough evaluation to make sure that that medication is appropriate for the particular target behaviors that you're witnessing. So next slide. We're going to save lots of times for questions at the end. So kind of leaving this open for hoping that some of these things stimulate some conversation and questions at the end. I have lots of stories if we run out of time, but be sure and if you have questions along the way, be sure and jot down your questions so you can ask them at the end. So approaches to behavior symptom management. One of the first things you want to do is you want to describe the behavior, and the behavior that you're describing needs to be something that if you say it or you write it down on paper and your night nurse is monitoring for the same thing, that you guys are speaking the same language. So anxiety, not a behavior. Anxious, not a behavior. Restless, not a behavior. You have to have something that's very specific, like spitting at staff during cares, or hitting staff during cares, or some kind of a descriptive behavior. So that's the first thing. Once you describe that behavior, that's going to be the behavior that you track the duration of the time that they're on the medication. The next thing you're going to rule out underlying disorder. Obviously, that's going to be a physician. Usually, delirium is more rapid onset. So, if you come in today and Mrs. Smith is acting completely different, that's delirium. If it's a gradual issue, then that's more of a dementia type thing, and that's kind of what we're talking about. Usually with a delirium, there's some sort of a medical issue like a UTI or some sort of a pain issue or something that they can't describe. But we're talking more about dementia and a slow gradual onset. So the next thing you want to do, identify a trigger. So what happens just before they exhibit the behavior? That's going to be a trigger. And what you need to figure out as a detective in a team with your pharmacist and your medical director and your CNA and your nursing team is, how can you change your approach to eliminate or soften that trigger for the behavior. Non-pharmacological approach, those are the kinds of things that you want to look at and talk about. You know, we've had anything from music therapy to, you know, like I had a gal that had the worst behaviors, and I talked to her family. Her family happened to be visiting, and asked them. I said, you know, what did she really like in her day? And they were like, oh, she just loved Lawrence Welk. And I was like, huh. So I'm sitting at the nurse's station, and I have my computer open. I throw on YouTube. I bring up Lawrence Welk, and she was sitting in front of me. I threw on Lawrence Welk, and that lady's eyes completely lit up, and she sang every single song in its entirety while I was sitting there. And I passed it on to the director of nursing. And when she got riled up, they would play Lawrence Welk for her. And it really helped her. And so there's a whole variety of non-pharmacological approaches. We'll cover a little bit of that in a minute. But really, the best thing you can do is talk to family, you know, any kind of information that you can gather about history, what their likes and interests were in the past, and try and talk about it as a team to figure out how you can use that as a non-pharmacological approach to the behavior. And then once you get to this step, obviously, we all know we get there, ordering medication, and then hoping your pharmacist has the knowledge to be able to help you choose an appropriate medication for the behavior. Next slide. So again, identify target behavior and trigger prior to the medication start. Track specific behaviors. Now, this has never happened in the history of me being a consultant, but if you could track behaviors for like 4 or 5 days before you started a medication, then you would be an absolute superstar, and you would be able to tell if the medication is working or not. You're going to be monitoring for behavioral episodes. So once you identify that target behavior and you actually start a medication, then you have to quantitatively and qualitatively monitor for those behavioral issues on a shift-by-shift basis. Always care plan interventions, looking at you know, care plans, things that you're trying to minimize. Obviously, you're trying to minimize side effects and maximize quality of life. Monitoring for outcomes and side effects. Outcomes is reduction of behaviors, and side effects are obviously behaviors. Always include your CNA's assistants reporting to nursing and filling out the behavioral tracking forms. You got to figure out exactly who's doing that, because sometimes if the CNA is reporting to the nurse, sometimes there's a little static and the wrong information gets reported in. So you want to make sure that you have a clear communication and a very descriptive behavior, and they're talking about triggers for each behavior. Go ahead and go to the next slide. I have seen a lot, and there's some really fun videos out there, but honestly, approach is everything with dementia. And you need to use foreshadowing. You know, one of the best videos I've ever seen is and I used to play this for these workshops, but it's a video of a gal that they're taking to the shower. And I mean, imagine, you know, humans are pretty private people. We go through life, and you don't like shower with a group of people, right? You're showering by yourself. You're very, you know, people are very individual, and they're not undressing in the hallway and then jumping into the bathroom. But they showed us a video of this gal that, you know, she's got dementia, and the nursing staff's in a hurry, and they're short bath aid. And so, you know, they're trying to scramble and get everything done. And this gal comes in and grabs her, and the next thing the dementia lady knows is she's having her clothes taken off, and she absolutely freaks out. And so they really try and you know, foreshadowing. Tell her 5 minutes before you're going to do it, hey, remember, we're going to go take a bath. Now remember that, right? And really giving them their personal space and trying to remember that, you know, we can't always do things my way. We need to work a little bit more on individualizing the care, showing them respect and calmness, and try and not portray that we're short-staffed, as I know we all are. Next slide. This is a pretty busy slide, but just kind of some things to think about for non-pharmacological treatment categories and strategy. Kind of look over there's music therapy. I've heard a lot. I've actually heard music therapy quite frequently with headphones and finding out what kind of music they like. I've seen a couple gentlemen really love old Westerns, and they'll play old Westerns for them in their rooms. Really trying to think about what we do and the way that it triggers their behavior, and try and think of a way that we can minimize what we're doing for that trigger. Next slide. And again, these are that's actually kind of a duplicate slide. So just some things to look at. And then my last slide is the next slide. And, you know, again, we're going back to individualized interventions. And remember, you know, target behavior, trigger, and then coming up with a personalized, individualized approach to minimizing the behaviors, minimizing side effects, and maximizing their quality of life. And the best way you can do it is work together as an interdisciplinary team, including your pharmacist. And, you know, hopefully once you get to that point of having to start a medication, then the pharmacist can help guide you with that appropriate choice. And I will say that antipsychotics do have their place, but they definitely shouldn't be the first line of therapy. So I'm going to pass it back to Jesse, and then we will get back to me with some questions towards the end.
Thank you, Dave. And actually, before we go to the next slide, I do have a question I'm going to sneak in on you. I know you mentioned music. As you know, the focus is on person-centered care, and we look at proactive approaches versus reactive approaches. What intervention have you seen that seemed to be the most profound for you, or that you've experienced? Again, I know you mentioned the music with the resident. Is there one that sticks out to you, an intervention that was kind of eye-opening?
Sure. You know, I actually have, I probably have about 50 stories like this that I love to tell. And I do have my favorites. And this is one of my favorites that I always think about. I got into a facility and I was covering for another pharmacist, and the director of nursing had asked me to take a look at so-and-so resident and said they were being sexually inappropriate and wanted to know if I could ask for an increase in the Zyprexa. Zyprexa was at like 5 BID, and they wanted to go up. 5 BID is a pretty good dose. So I was interested, and I went in and took a look, and I really had to gather a bunch of information from a lot of different people. I had to include the CNAs. The CNAs usually know the most about the trigger and what's going to make the behavior happen. They report it to the nurse. The nurse may not have as much knowledge. They just know that the behavior is occurring, and they report that back to the team, and then a med gets started. So there wasn't really a lot of research surrounding why he started on the Zyprexa. Find out he was sexually inappropriate. He was grabbing women's front sides and back sides. And so through research, found out that he was newly admitted to the facility. He'd lost his sight and hearing over the last 6 to 8 months and was progressing in dementia. And he was hard of hearing. So I think I said that, hearing and sight. So I went and watched a couple of people interact with him, and he was in a wheelchair, and they would walk over and they would put their arms down on his wheelchair and lean over him because they couldn't hear him, or he couldn't hear them. And they would proceed to yell in his ear so he could hear. And he would reach out to orient himself, and what's right in front of him is the front side of whoever's caring for him. So that was perceived as sexually inappropriate behavior. And he didn't really know what he was doing. He was just trying to orient himself, because all of a sudden he was just sitting there and he hears this voice in his ear and he doesn't know what's going on because he can't see. So we talked about an individualized care approach with him. We said, hey, don't approach him from the front. Approach him from the rear of the wheelchair, put your hand on his shoulder and let him know that you're there. And then if you got to holler at him, holler at him. But he absolutely did not need the Zyprexa. We DC'd it. And with just a very simple approach, we completely changed his life. So, those are the kinds of things I'm talking about with simple interventions, identifying triggers and figuring out a non-pharmacological approach that you can manage the behavior.
Thank you. Thanks, Dave. Thank you for sharing that. I feel like those types of experiences, if we can share them amongst ourselves and amongst these different long-term care centers, those types of experiences can help others learn and how to address those resident needs or how to approach them from a different angle, perhaps. So thank you. I appreciate you sharing that. So with
You bet.
that, Mary, let's go ahead and we'll dive into some data. If we'll go to the next slide, please. All right, so where are we then as far as antipsychotic rates for our states? So I was able to partner with our data analyst with Mountain Pacific Quality Health, and he pulled the most recent data he could pull together for me, specifically for this presentation, through Q3 of 2021. And we're able to look at antipsychotic rates for Alaska, Hawaii, Montana, and Wyoming here. And you'll notice on here the number of homes that on each individual graph, that's going to be the number of homes that's included in this. So Alaska, 20 centers, Hawaii, 44, Montana, 73, and Wyoming, 36. Before I get into that data, I want to kind of bring up a few things historically and let you know where some of this information came from. So actually, it was back in 2012 that they started reporting on this antipsychotic rates. And that data that was pulled and generated in 2012 actually was pulled from the last 2 quarters of 2011. So as we look at these slides today, we're almost, 10 years into this reporting and looking at these metrics. So I thought that was kind of important because as we look back in time historically, in 2012, like David mentioned, 83% of atypical antipsychotic drug claims were for the elderly. And the prevalence rate in 2012 was 23.8%. Today, when we look at our graphs, we're at a national prevalence of 14.6. So we've come a long ways, 23.8% in 2012 down to 14.6. So we've had some goals set before us. We've by the end of 2013, antipsychotic use across the nation, we reduced that by 15% within a year. And we've continued to set forth those goals. And in 2019, again, we were at that 15% reduction goal. It's kind of put on hold a little bit because of the pandemic. And some of you guys have probably seen the release yesterday to anticipate the new reduction goals in April. So we'll see how that filters out on here. But again, I just wanted to bring up that, boy, 10 years ago, we were looking at 23.8% as a national prevalence, and now we're at 14.6. But what's in front of us, obviously, for each state is we've seen a little bit of an incline since 2019. You can't help, and that's a whole nother topic probably for a whole nother presentation, but you can't help but associate some of that incline likely being associated with the pandemic. So how do we line up against our partners? That red line on there is going to be your state peak. And then Mary, go ahead and go to the next slide. So there we can compare ourselves amongst our serviced region. So no surprise, maybe, state of Hawaii, I guess they have a cultural thing. I hear the weather is very nice. So their antipsychotic use seems to be much lower. And on top, I guess, is state of Wyoming. So interesting. I'm not sure if you guys are surprised by any of this data, but I certainly wanted to share it forward because I was surprised on how far we've come in 10 years. I thought that was pretty substantial. Dave, does that surprise you at all?
The only thing it makes me think is I need to come out to Hawaii and do some presentations about what a good job they're doing, or maybe do some research on how they're doing so well. But
I would agree.
I think it's all about the pandemic, lack of staff. People are short-staffed. The residents are being isolated, not seeing their families, and I think that's going to escalate behaviors. And we're all trying to do the best we can, but there's not one person on the phone right now that isn't affected by short staffing.
Yeah, I would agree. Mary, let's go ahead and look at the next slide. So that data we just looked at, where did all of that come from? Well, for folks that may be new to their positions, or I know there's been a ton of role changes, all that data comes from MDS, and those resident assessments that are submitted by your MDS, and those essentially convert into your quality measures, which are then used for programs, such as your 5-star quality rating systems. So, your MDS, that's where that data comes from. And so I want to emphasize the value in training and ongoing education for your MDS coordinator, as well as consistency. So again, like Dave has mentioned, I know we're short-staffed in places, and it's very likely your MDS is working the night shift or covering weekends for you, or covering the floor. It's something to be aware of, is that don't forget, your MDS coding accuracy is absolutely fundamental and essential into your quality measures. So we really want to make sure that that coding is accurate as possible. And again, ask yourself, and do you know if your MDS coordinator is aware of the exclusions, like David mentioned earlier in the presentation? The residents with schizophrenia, Tourette's, and Huntington's disease are excluded from those antipsychotic metrics. Does your MDS know that? And the impact, obviously, that could have as that filters out in your quality measures. And another highlight too, when we talk about MDS, and these are just a few common things that come up sometimes with new folks, and kind of misunderstandings or educational opportunities, is, does your MDS know when they code that any medication that has a pharmacological classification or therapeutic category as an antipsychotic has to be recorded as that? It's not why the medication is being used, it's how it's classified. And that's where some coding errors, they get caught up. So again, educational opportunity, it's not how the med's used, it's how it's classified, and are they coding it right? A couple of reminders with GDRs, again, this conversation of, does your MDS know that if a resident was admitted to the facility with a documented GDR attempt already in progress, and they received the last dose of that med in your facility, then you would code that GDR. So those are the kind of things that, sometimes, again, you have folks that may be new to the roles or sharing roles, that you want to make sure that they have a current RAI manual in front of them, that they are aware of those coding specifics, because they will have a direct impact. And being mindful to offer those educational opportunities and ongoing education to our MDS folks. And also that MDS, are they updating your care plans when they're doing their assessments? Are they updating your risk assessments, maybe your falls, your aims? That kind of all plays in if you do have folks on antipsychotics, and then maybe, how your survey outcome may look if those things aren't in a line and they don't match and they're not updated. So make sure, again, those conversations with MDS, and that MDS individual is not siloed and is really part of that team and team discussions to make sure that we kind of have everything aligned, but we're also providing the best resident-centered care available.
Hey, Jesse, this is Marcy. Can you hear me?
Yeah.
There's a couple questions in chat. I don't know if you wanted to take these as you go or if you just want to address them at the end.
The melatonin one we can do in the end. The question that she had was, is this per capita? I think that was the information on percentage.
Oh, it's per center. The numerator in there, I believe, is center. So on, I think 73 for Montana, that's number of nursing care centers. And I'd be happy to send out, there's some great resources on translating your center's CASPER report and quality measure reports. And we would be absolutely delighted to send that out to you after the call if anyone's interested or feels like that would be helpful. Perfect. Was there another one, Marcy?
That was it. Just the melatonin one that we're going to hit at the end. And Paula's question, is this per capita? And
okay.
Paula saying, yes, please, if you could share that, that would be great.
Okay. Yeah, that sounds great. Yeah, we'll send that out. I love it. I'm all about resources and connecting people with resources. Great. So just a reminder too, kind of more of a public service announcement since we have the opportunity here. And we look at antipsychotic medications and compliance. Don't forget about watching those orders from outside vendors or outside prescribers such as hospice. I have seen in the recent years where folks, it catches up with them because they think that hospice is an exclusion and you don't have to monitor those medications if they're prescribed from hospice. And hospice, they sometimes write for a medication that to control conditions, nausea, vomiting, but really there could be a less restrictive medication. And that's just a matter of making that phone call early on and getting that order converted. Those orders do sneak in. Before you know it, you have them in front of you and you didn't realize that, oh, I do have somebody on antipsychotics. I didn't realize that. Who is it? Well, that's typically one avenue that they can sneak in on you. So I just wanted to add that in there. Okay, next slide, please. Supporting the team, just again, ask yourselves, and a good reminder that that staff members and family, they play a critical role in behavior management and non-pharmacological interventions. And just like what Dave shared is those conversations and that outreach to family can have a immediate impact on managing that resident and quality, quite frankly, quality of life for that resident, and having that proactive approach versus reactive approach to behaviors. And that family, I've seen where they are the key holders to behaviors. And I've seen where residents, for example, they act out differently around a particular CNA. And then you have a conversation with the family and they go, you know what, that really looks like his cousin or her cousin that they didn't get along very well and they fought all through their lives. So putting those two and two together, that, oh, that CNA reminds the patient of that person that they didn't get along with, well, that would make sense on why that behavior is occurring. So involving the family in those discussions is of utmost importance, and staff members across all role sets. And again, just reiterating what Dave said, that CNAs are critical to be involved in those conversations. And do staff members have educational opportunities and resources to better understand cause and effect, the whys, the triggers, the reason behind the behavior? And what comes up a lot that I have seen in my own experience is staff members aren't given the tools to identify unmet needs. And addressing a behavior maybe related to unmet needs. So I bring that forward as an educational opportunity, just to discover that more within your staff members. What is an unmet need? Is someone thirsty? Are they incontinent? Are they uncomfortable? Did someone forget to put the cushion in their wheelchair? Are they in the wrong wheelchair? Those are just a few examples, that again of triggers. So with that said, next slide, please. So the power of team, just, friendly reminders, again, as we looked at some of our polls in the beginning, we do have some opportunities here. And for the 25 to 38% of you, I would highly suggest looking at the benefits your center would receive from having a behavior monitoring committee, a pain committee, having those two people talk and perhaps overlap a little bit. And then again, involving family in behavior management and close contact for, care planning and suggested interventions. So again, I can't emphasize the power of the team enough. So next slide, please. So as we reflect back, we kind of went over a little bit of the why of the GDRs, looking back to about 2011 was a key point, or a changing point in our history. Emphasizing the individualized care plan and the importance and value behind the center patient-centered approach. Non-pharmacological interventions. I got to say, I love music. I've seen it work myself, and I'm glad that you brought that up, Dave. Antipsychotic rates. It's interesting to see how we compare against our neighbors and how just the pandemic likely, had an effect, but also cultural and environmental effects too, I feel, and staffing. MDS highlights, make sure we're having those conversations about proper coding and accuracy. And again, I can't emphasize enough about the importance of the team approach to managing behaviors and your GDRs. So with that, I think we have some time for questions. So next,
and
yeah.
Let me address one of the questions that came up in the queue about melatonin. Melatonin is a very commonly asked question, and there is some evidence and some research out there that says that the most effective dose is around 1 milligram, and you shouldn't be going to over 1 milligram. And if you do go over 1 milligrams, it can actually have a paradoxical effect. So, the one thing that you really need to be taking a look at is did the melatonin actually work? Because a lot of residents that we DC it in, we don't see any change in sleeping habits at all. So, give it a real trial. I always recommend monitoring hours of sleep per shift when you start anything for sedative hypnotics, and then you can see that's your monitoring for efficacy and safety. But generally, the diagnosis you should list is health maintenance or supplement, and then you do not need to review it to taper. If you list it for insomnia, or if it's a PRN, then you have to follow the PRN rules and the insomnia rules. But it's considered a supplement, and that's definitely what I would list it as.
Great. And Marcy just put in the chat box there too some resources that I see some questions too. Peggy, I see your question, and I'm going to ask Dave. You bet. Marcy just put in the chat box the link so that you can pull up those comparisons of antipsychotic use state by state. I will tell you that on their CMS website, it's only through Q2. We were able to do more recent data through Q3. So if you're looking at it, just make that notation. But she did put some links in there for you guys. But Dave, we have a question here from Peggy.
Peggy Trussell. I love her.
Yes. Hi, Peggy.
I've worked with her.
Long time no see. Please, do you have some suggestions on how to address challenges when the doctor will not accept the GDR recommendation?
Yes, and that's a tough one, and that's something that you definitely want to work with your consultant on. But what does a risk versus benefit look like? A risk versus benefit has to do with you're evaluating if the med is working and if there's any side effects. So, you know, no changes. Like if a physician says no and his comment or her comment is no changes, that's not a risk versus benefit. So you have to have some sort of an acknowledgement of the medication and that, you know, it continues to be valid and risk of tapering it would, you know, cause harm to the resident's well-being or something. A lot of different things that could qualify. But if you have a physician that recalcitrant physician that just is not going to accept it, then there are some ways around that. And some ways around that we've done in the past is I actually created a bunch of forms, and I haven't used those forms in a long time, but I was back at a facility in Libby, Montana, and they're still using my forms that I created about 20 years ago. And I was so excited to see that they're still using those. But basically what it is it's kind of a form that I created. You can work with your pharmacist to create something, but I had like, you know, some blank lines where you could say, Mrs. Smith is on Zyprexa, the dose, how long, and the duration. Then it had some information. And then I had a place that said, the interdisciplinary team has met and wants you to consider the following. And then we would actually meet and talk about the resident. And excuse me just for a second. I had to cough. Okay. We would discuss the resident, and then we would put the rationale on the piece of paper. And so you would actually have a rationale there. And then we would say something along the lines of, you know, physician, please sign below if you agree to a no taper. And then they check a box and sign it in data. And that qualified and worked actually pretty well. So you kind of have to work as a team, figure out what's going to be successful. You know, consult with your pharmacist. If your pharmacist isn't really coherent with GDRs, ask for a different consultant, because if they're consulting and they don't know about GDRs, then you need to get somebody in there that does, because that's super, super important. Most of the citations that I see, that I've seen over the years have always been surrounding psychotropic drug use. So super, super important that the consultant is up on that kind of stuff.
Thanks, Dave. Peggy, I hope that helps you. If not, chat back with us and we'll see what we can do here.
She'll just call me anytime she wants.
Yeah.
I love talking to Peggy. She's awesome.
I have another question for you. What should the documentation look like for a failed GDR? What should be included in that documentation?
You know, there's a little known fact, and most surveyors probably wouldn't be able to recapitulate this, but if you have an antipsychotic being used for dementia, in the first year of therapy, you're required to try an on-site GDR. So you actually have to try a reduction. What that looks like as far as time frame and all that, that's up to interpretation. But you are actually supposed to try an on-site reduction. And so your risk versus benefit comment would be relating to symptoms returned on trial taper. Or, and like I said, I mean, I don't think many surveyors know that rule, and I'm not sure that they're really focused on that. But at the very least, you need to have very clear information on what kind of harm you could bring this potential resident if you tapered the medication. And I can tell you from a lot of years of doing this, most of the time, if you have somebody that's controlled and they're on a lower dose and you stop it and their behaviors return, most likely you're going to have to give them a much higher dose than when they were on the medication to actually stop the behavior, which is going to bring around more of a chance of side effects. So, you know, I always, when I'm training consultants and I'm talking to people, I'm always saying, okay, we're going to take a look at the effectiveness, which is the behavior monitoring, and potential side effects. And you have 4 different things that you could have. You could have no behaviors and no side effects. You could have behaviors and side effects. You could have, you know, 4 different mixtures. And then there's a rationale and a reason as to why you would want to taper in each one of those situations. or not taper and provide the documentation as such.
Thanks, Dave.
I hope I'm making sense.
Yes,
I'm just talking to a screen and I don't see anybody. So I know Peggy's out there.
It sounds like, we have some opportunities to collaborate and assist with some forums for folks that are struggling with some of these challenges. So for those of you that have put in the chat box that you'd be interested in those resources, we will absolutely pull those together and reach back out to you guys. Dave, I have another question for you too, and hopefully I can squeeze it in before our time is up today together. It's kind of a big one. So again, as we look at roles and some challenges in our long-term care facilities and with our partners right now, what's your advice for a brand new DNS that maybe just got her keys to the office today, walked in and saw a pile of GDR sitting on the corner of her desk? What is your best advice to manage those?
You guys would not believe how many times that I've actually seen this situation. And, I would honestly, the best thing that you can do is get on the phone with your pharmacist and get a temperature check on where exactly you are, how far, like how long it's been since you've been, caught up, and really come up with a game plan, because you can't change anything that happened before you got there. And that's just, it is what it is. You need to draw a line in the sand and say, I can start making an impact today, but I can't fix what happened yesterday. So you contact your consultant pharmacist, you find out exactly what position you're in as far as, how exposed are we to potential tapers, and come up with a game plan as a team on how you're going to handle that. And you're going to want to include your administrator and your medical director, but come up with a game plan. And there's no way to backdate reviews or anything, but you can certainly get things up to speed in a very quick form. And I have a consultant that I'm training right now, and we have some challenges in a couple of facilities where things haven't been done in a few months. And what we try and do is we say, okay, don't worry about January and February. Okay. We're going to do a comprehensive review for you in March, and we're going to provide everything that you need. And, let's get the stuff done for March and move on. But your consultant pharmacist will be a really valuable tool to be able to give you an idea of exactly where you're at with a time frame.
Thank you, Dave. I appreciate that. I feel like there's a lot more of those folks in that seat, and we are sharing a lot of those experiences. So again, however we can help each other out and connect those resources. I just can't emphasize enough the value in a pharmacist. So as we look at some of those polling questions, if you have an opportunity to involve your pharmacist, I would encourage you to do so. And whether that's in committees or conversations around resident-centered care, they're definitely a key member in our team as well. It looks like we have a comment in the chat here too. Judith says, just a suggestion for the new DNS. As a new DNS, she can ask for the Casper report and start looking at trigger areas, including residents, patients with triggered psychotropic use and with behaviors. Good point. Good point. And again,
that could actually be a whole presentation, but thanks for bringing that up, Judith. That's something that you should be asking your consultant pharmacist. Ask your consultant pharmacist if they're reviewing the Casper report and looking for ways or areas that you're exposed. And what we mean is you're going in to look at the reporting stuff for short-term and long-stay residents. And so if you have a high rate of long-term residents on antipsychotics and a high rate of falls and pressure ulcers and things, then you're gonna trigger for a review of those residents during your annual inspection. So really understanding those Casper reports, and the way I look at them is I just go in a nursing home, compare, and you can bring up your facility and bring all that stuff up. Do you have any other way to do that, Jesse?
No, I think that's a great recommendation. And again, we'll send out some resources about Casper's and you know, again, if folks are new to their role, don't hesitate to reach out. There's individuals that can assist you. So yeah, perfect.
Yeah.
Yeah, great
And
comments.
also there was another comment in there on you know, try and take a course to get an overview. Lindsay had mentioned that she didn't understand the quality measures or 5-star rating until she had a little bit of experience. And there's so many things out there, guys. I mean, you can just YouTube something and just YouTube 5-star rating. YouTube dementia approaches, non-pharmacological approaches. There's a ton of stuff out there. Give you great ideas, super easy. You can even bring it in a in-service type format where you just, you know, sit down and buy everybody a slice of pizza and make them watch it. But tons of good resources out there. And I know Mount Pacific has some great quality resources that they can provide as well.
Yes, Teepa Snow videos. Yep, Peggy. Yep, those are great. Yeah. I guess with that said, Mary, if you wouldn't mind advancing to our very last slide. Well, we have the resources on the next slide. And again, we'll send all these out. But save the date. Again, this was part 1 of a part 2 series. Our time has come to a close. I'm super appreciative for all of those that attended today. I am super appreciative of Dave Lawless for joining us today and for his expertise. And stay tuned for part 2, Tuesday, April 5th, as we partner with a center, Wind River Rehab and Wellness out of Wyoming. So thank you again. We'll send out all these forms and resources. You guys have a wonderful afternoon. Take care.
Thanks, everybody. Have a wonderful day. Appreciate y'all.